In this presentation, I'm going to go over how to assess the knee. This is a secondary assessment. Again, I don't use the HIT process as much because I do a little bit more than the H, the I, and the T. We'll talk about more than just those areas because I want to talk to you about some stress and special tests in this. So our history is the same kind of steps that we would follow with a foot, ankle, and lower leg. We're trying to determine, we're trying to answer and solve the mystery question of what injury this is by asking general questions first. How'd you get hurt? Where's your pain at? Can you describe your kind of pain? All those type of questions that we discussed about and shown in the foot, ankle, and lower leg. We're going to follow those with every injury that we do. We want to gather as much about the history from the injury and even before the injury. Did they ever hurt that leg or their knee before? So follow those same steps. And after we do our history, do our visual inspection, bilateral inspection, always compare the good to the bad. We expect for structural or biomechanical abnormalities such as guineavarum, valgum, and recuvarum. So guineavarum is bow-leggedness, guineavalgum is knocked knees, and guinearecuvartum is hyperextended knees. We continue our inspection. We look for swelling and deformity, abnormal contours, or discoloration. We inspect their gait. Well, that means we watch them walk to see if we can see if they're favoring their leg, their knees not extending out normally, they're not flexing normally. Might have them do a squat, those type of things, just to see if we can find any clues to what's wrong with them. We can do girth measurements to determine if there is any atrophy, which means the loss of muscle mass or swelling. So girth measurements are taken on both sides, the good and the bad, and we have various spots. And again, this is for an advanced athletic training class or physical therapy material, but you do measurements like this, compare the good to the bad, and see if there's more swelling, less swelling, muscle atrophy. Palpation, I provide another video on how to palpate the knee. Then we do range of motion testing, both active, passive, and resistive range of motion testing. So we have a flexion, again, it's bringing your heel towards your butt. The full range of motion is about 135 degrees, and that is done by your hamstrings. Extension, which is straighten out the leg. So there's not really any extension that beyond this straight, and that's done by our quadricep muscles. We have internal rotation, external rotation, and you can see the muscles that do that in our range of motion. So after we do our range of motion testing, see if there's any weakness, any decreased active range of motion, decreased passive range of motion, any decreased muscle strength, then we do some special tests. So we have the first one we talk about is the anterior drawer test. This tests the ACL. So you can see that the athlete or the patient is lying on the ground, not on the ground, it could be on the table with their knee bent or flexed, 90 degrees, with the feet flat on the table. Usually sit on the person's foot. We cup our hands around their knee and draw the tibia anteriorly, and the positive sign is the tibia actually moves forward more than the uninjured side. Again, you can see videos if you're interested in this more. Go on YouTube, you can find tons of video of these things. So our posterior drawer test is for the PCL, same as the anterior drawer, except we're pushing down or pushing posteriorly, and the positive sign is that it moves more on the posterior direction than on the anterior direction. And again, pain is always a positive sign. Lockmans Test, another ACL test. This one takes a lot of work to get used to, a lot of practice. So the patient's supine or on their back, knees passively flexed about 20 to 25 degrees. You have one hand that grabs the bottom or the distal of the femur, and the other hand grasps the proximal of the tibia or the top of the tibia, and we try to draw the tibia anteriorly and posteriorly, as you can see in C there. And the positive sign is if the tibia moves anteriorly or up, that's a positive sign. Again, pain is always a positive sign. Our next special test is the Valgus stress test. This is for the MCL. So we have the athlete lying on supine on the table, leg is relaxed. We got one hand around the distal medial leg and one hand on the lateral knee, and we apply a valgus force, or we're trying to abduct, pull away from the midline. The positive test is laxity or more than the other side. Again, pain is another positive sign. So we push and pull there. We're not really pushing into the MCL, but we're pulling the lower leg. The Varus stress test is for the LCL. Same position that we just had them for the Valgus test, except now we got one hand on a distal lateral lower leg and one hand on a medial knee, and we apply a Varus or a adduction towards the midline, and we're seeing if there's laxity that opens up more than the uninjured side. Next tests are special tests. So these identify specific injuries again. So we have McMurray's test. This is going to test for meniscal tears. So the athlete's lying supine. We palpate the joint line. We do that by see on the picture the guy's hand is on the knee. We would internally and externally rotate the foot, and we can feel the top of the tibia, and that's where we can find the joint line. Then we move the leg passively into flexion, rotate the tibia externally to stress the medial meniscus, and internally to stress the lateral meniscus, applying a valgus and varus force. This one is kind of hard to explain. You just have to see it. Again, if you're going to go into sports medicine or athletic training or physical therapy, occupational therapy, you're going to take classes in all this stuff. Athlete's compression test. We, again, determine if we have a meniscal or a ligament injury. I don't think this is the greatest test in the world. So the athlete's lying prone with a knee flexed 90 degrees. We internally and externally rotate the tibia while compressing the tibia against the femur. So we're pushing down and pulling up on the. So the compression is when we push down and internally and externally rotate the tibia against the femur. And our pain with compression indicates a possible meniscus tear. Our last test is called a grind test. This is used to identify patellofemoral or patella. I just went blank. Use patellofemoral or patella tendonitis. So the knee is fully extended and quads are relaxed. We push the patella into the femoral groove. See the hand up top of the tibia, or the top of the knee, is pushing the femur. Come on, brain. The patella into the femur, to the femoral groove. Then you instruct the athlete to contract their quads. The positive sign is pain, and this is again, I don't think it's the greatest test in the world, because somebody can have the chronomalacia patella, or another injury that we didn't talk about is patella spike. Patella, there's bits and pieces in the patella, and it's just really not an injury that we talked about in class. Our functional tests, and we use to follow the same steps that we did with the foot, ankle, and lower leg. We have them walk, run, jump, in various activities, straight ahead, start going back and forth, zigzags, figure of eights, and then become more sport related motions to see what they can do. So that's a quick and dirty explanation of how to do an ankle or a knee assessment.